Good evening, everyone. Today, our topic of discussion is on ischemic heart disease. Okay, this is the topics. First, we'll go with chronic coronary syndrome, which was before called as stable ischemic heart disease. Second, we'll go for NSTEMI, unstable angina. Third, we will discuss about ST elevation MI. Okay, first going to the question. Okay. So this is the question number 1. Very good. Most of you answered correctly. So this is the all are determinants of myocardial oxygen demand except the heart rate, myocardial contractility, myocardial relaxation, and myocardial wall tension. Actually, heart rate, myocardial contractility, and myocardial wall tension all are determinants of myocardial oxygen demand. So only we use beta blockers, which reduces the heart rate and myocardial contractility in angina. But myocardial relaxation is not determinant of myocardial oxygen demand. So the answer for this question is option 3. Most of you answer correctly. Very good. Okay. So this is the pathophysiology. So the major determinants, as we discussed, the major determinants are heart rate, myocardial contractility, and wall tension. What happens? There are 3 sets of vessels in the coronaries, so which are classified as R1, R2, and R3. So first R1 is large epicardial arteries. The R2 are arterial vessels, and R3 is intramyocardial capillary vessels. In the absence of any stenosis, the resistance by R1 is very small. R1 is very trivial. So major resistance is contributed by R2 and R3. If there is stenosis, R1 contributes to significant flow resistance. So this is the coronary circulation. You can see these vessels. This is the R1, which is, see here, either this is the percentage of total resistance to flow, which is very minimal. So R2 and R3, there is maximum resistance in normal coronary circulation. In atherosclerosis, the major contribution to atherosclerosis is R1, because the stenosis is here, which leads to the increased resistance. So then the main function of this is R1 is transport. So R2 and R3, there happens main regulation and exchange of nutrients in the capillaries. So main we have to know about the ischemic cascade. So this ischemic cascade is very important, because when the patient comes with angina, actually he is in the ischemia or angina is in this phase, but there are many phases before which happens. So first is metabolic changes. Second is perfusion changes. So on any patient with stable ischemic disease, we plan for myocardial perfusion imaging, which occurs very before to ECG changes and echo changes. So perfusion changes. And the third one is diastolic dysfunction. Then fourth one is systolic dysfunction. Then finally ST changes. Before the patient develops ST changes, there would have happened a myriad of changes. So before which we can be detected by other tests like myocardial perfusion imaging, cardiac MRI to see for viability. Then further the ST changes, when the patient comes with angina, they would have been in this stage. So this is the ischemia cascade. So this is the ischemic cascade. Next, coming on to the stable ischemic heart disease or chronic coronary syndrome. So this now, before it was called as stable ischemic heart disease. Now it is called as chronic coronary syndrome or CCS. So this any patient with CCS will have a typical angina. So typical angina we already discussed in the chest symptomatology chapter. So in this typical angina is patient is having retrosternal chest pain, which is increased by exertion, reduced by rest or nitrates. So these are the 3 points. All 3 points should be satisfied to tell it is a typical angina. So based on this typical angina, you have to classify the symptoms based on Canadian Cardiovascular Society classification. This is similar to the NYHA classification. So here you can see this is grade 1, grade 2, grade 3, grade 4. This is during strenuous exercise. And this is during same which when you read NIA also same slight limitation of ordinary activities. That means patient will have angina while walking uphill or walking more than 1 flight of stairs. But in Canadian Cardiovascular Society grade 3, patient can't even walk 1 flight of stairs. So then class 4, patient will having angina at rest. So these are the 4 Canadian. These are these 4 grades for angina according to Canadian Cardiovascular Society. So then coming on, whenever a patient presents with stable ischemic heart disease, we have to find out whether the patient is having the pain is due to cardiac chest pain or non-cardiac chest pain. So if he is having cardiac chest pain, then we have to confirm with ECG and further chest. So first we do ECG. So in most patients of chronic coronary syndrome, ECG will be normal because patient will have ECG changes only during exercise. So we have to perform stress test in the form of stress ECG or stress MPI or stress echocardiography. So otherwise, we can see directly the coronaries via cardiac MRI and CT coronary angiogram. So first basic investigation. First, we have to see whether the patient is having cardiac chest pain or non-cardiac chest pain. When you confirm the patient is having cardiac chest pain, we have to confirm he is having significant coronary artery disease with these investigations. So this further will. So next question we'll go to the next one. So these are the all are contraindication for stress testing except unstable rhythm with hemodynamic compromise, severe symptomatic AS, infective endocarditis, severe mitral regurgitation. Most of you answered as infective endocarditis, but active infective endocarditis is a contraindication for stress testing. Actually, in the correct answer for this question is severe mitral regurgitation. Severe mitral regurgitation, because in patients with mitral regurgitation, to see for functional capacity, we do TMT. See for functional capacity, it's not for ischemia. So this is actually indication. See for functional capacity of the patient. So all others are in the unstable rhythms, you can't do this one. Severe symptomatic case, already the patient is having a decreased stroke volume. So in this patient also you can't do stress testing. Acute infective endocarditis, what happens? There is the infective endocarditis may dislodge and cause emboli and stroke. So the answer for this question is not infective endocarditis, it is severe mitral regurgitation. So what all we see in the we do a stress TMT, which is also called as TMT. So in TMT, there are indications. When the patient comes with chest pain, we have doubtful whether the patient is having cardiac cause of chest pain or non-cardiac cause of chest pain. At that time, we do treadmill test, which is a stress test. So in this, there is a graded exercise protocol. Graded exercise protocol. Most commonly, we follow is Bruce protocol. In this, the treadmill runs at a specific speed and at specific inclinations. So in that, every 3 minutes, the grade and inclination will increase. So in that, we have to see some parameters. First is target heart rate. So any patient should achieve the 85% of the target heart rate. So you can ask how is the target heart rate calculated? So the target heart rate is calculated by the simple formula 220 minus age. For example, a patient of age 20 years is 220 minus 20. Sorry, 220 minus 20, it is 200. So patient should achieve at least 85% of the 200. So then only stress test you can comment. Whenever the patient cannot achieve this heart rate, the stress test will become inconclusive. So the target heart rate should be achieved. So in the stress test, when you go through the stress test report, they would have mentioned target heart rate achieved. So target heart rate not achieved. If there is a patient, if the patient is taking beta blockers, there is different formula to calculate. In that patients, the target heart rate will be, patient cannot achieve the heart rate of this much. So this is the main thing. You should achieve 85% of target heart rate. Second, you should see for what you will see in that TMT test. You should see for two things in ECG. One is ST segment depression, ST segment elevation. So main is ST segment depression. So whenever you see in the ECG, there will be graded exercise protocol. In that exercise, there will be ST segment depression. So which is more sensitive is whenever there is ST segment depression in the lateral leads. Whenever there is ST segment depression in the lateral leads, it is very significant. So which all ST segment depressions are significant? Mainly is downsloping ST segment depression. Downsloping or straight ST segment depression. So these are the ST segment depressions which are significant. For example, when patient is having upsloping ST depression, it is not significant. Upsloping ST depression. So mainly you have to see for downsloping ST depression or straight ST depression in the treadmill ECG. So then ST elevation is also significant. In one thing you have to remember in ECG is ischemia does not localize on ECG. This is very important. Ischemia does not localize on ECG. What this means For example, a patient is having ST depression in the leads 2-3 AVF. It doesn't mean patient is having inferior wall ischemia. This is the main thing. It is not inferior wall ischemia. But whenever the patient having ST elevation, it is infraction. So this is not inferior wall ischemia. This is very important thing. In ischemia does not localize in ECG, but whenever infract, you can localize this thing. Most often we write in our case sheets whenever you see ST depression noted in V5, V6, 1 AVL, high lateral ischemia. But you should not write like that. Ischemia does not localize on ECG. Only infract is there, you can tell which lead it is there. So mainly ST treatment depression you can see. Then you have to see for symptoms, mainly symptoms. So there is you have to ask the patient, angina, whether he got the same chest pain which he got before doing the treadmill test. So based on this angina, there is a calculation. Based on this, we have to calculate a formula and we have to grade the severity of this symptoms. Next, BP measurements. So in TMT, even BP measurement is very important. Whenever there is significant hypotension, we have to, this is the indication to stop the TMT because the patient will having severe stenosis of left main. So all this should be seen. Not only you have to see the heart rate, you should STD symptoms, and even BP measurement should be done. So this was the last question. So these are the contraindication for stress testing, which is rest angina within 48 hours, unstable rhythms, severe aortic stenosis, acute myocarditis, uncontrolled heart failure, severe pulmonary hypertension, and active infective endocarditis. You can remember easily. Contraindications mainly are the emergencies in cardiology, which is three big emergencies are acute MI, then pulmonary embolism, then acute aortic dissection. In these three things, you can't do TMT because these are acute emergencies. Other things are myocarditis, then acute decompensated heart failure, then infective endocarditis. These are all contraindications because all patients you can't send for TMT. So these are the contraindications. Last question is answer is severe MR because we assess functional capacity using that. Okay. So in this, after this, you find out the patient is having a chronic coronary syndrome, and at present patient is having chronic coronary syndrome. Then you start the treatment for the patient with first you start with anti-anginals. So anti-anginals, then antiplatelets, statins. If the patient is having hypertension or LV dysfunction, you can use ACE inhibitors. So antiplatelets for example, in chronic coronary syndrome, no need for dual antiplatelet, single antiplatelet therapy. Then statins. Okay, coming to anti-anginals. So anti-anginals, everyone will be knowing. The most important anti-anginals, first line drugs are nitrates, beta blockers, and calcium channel blockers. So in this, the nitrates, there are isosorbate dinitrate, isosorbate mononitrate, and glyceryl trinitrate. Beta blockers, you can use all class of beta blockers. There are except beta blockers with intrinsic sympathomimetic activity that we will discuss later. Then calcium channel blockers. So coming to the next question. All are false about beta blockers in the management of chronic coronary syndrome except metoprolol is contraindicated in renal failure. Pindolol is a beta 1 specific blocker. Beta blockers are the first line drug in Prince metal angina. Carvedilol as a vasodilating property. So you have to see the catch in this question. All are false about beta blockers. Okay, there is equal response for option 2, option 3, and option 4. So you have to read the question. This all are false about beta blockers in the management of CCS. So the correct answer for this question is carvedilol as a alpha vasodilating property. So because carvedilol is it is a combined blocker. It is both alpha blocker plus beta blocker. So due to the alpha blockage property, it has vasodilating property. So this is the first thing. So second is I have asked this third option. We'll go for third option. They are the first line drug in Prince metal angina. So Prince metal angina, beta blockers are contraindicated. Because beta blockers, for example, if you use non-specific beta blocker like propranolol, it causes severe vasospasm due to the alpha activity. So you should not use. So beta blocker, the first line drugs are for Prince-Metal angina, the first line drugs are calcium channel blockers and nitrates. So again, this question, this option, pindalol is a beta 1 specific blocker. No. So pindalol and acebutolol are beta blockers with intrinsic sympathomimetic activity. So this having some beta mimetic activity. So this also can be used in angina patients who have very low heart rates. For example, patient is having heart rate of 50. In that patient, you have to prescribe a beta blocker, or you can't prescribe a normal beta blocker. You can use this because it has intense sympathomimetic activity. It won't decrease the heart rate further. See, this is a beta blocker. Beta blockers are first line therapy in the control of symptoms for CCS, particularly effort-related angina. It is not Prince-Metal angina. This is effort-related angina. Next, metoprolol and propranolol are the beta blockers excreted in liver. So they are not contraindicated in renal failure. Full dose can be given of metoprolol and propranolol in renal failure. So the answer for our question is option 4. Carvedilol as a vasodilating property. Okay. So side effects. Everyone knows the side effects. So beta blockers, it decreases heart rate, contractibility. So then it causes bronchoconstriction. But beta blockers at beta 1 specific at low doses, it doesn't cause. Beta at low doses, no bronchoconstriction. Beta 1 at high doses, it also causes bronchoconstriction. So in a patient with COPD, you can use beta 1 blockers at low doses, not at high doses. Next, CNS side effects. Many CNS side effects you can have. It can cause depression. So it can cause muscle fatigue. Then worsening of peripheral artery disease. This is also in non-specific beta blockers. Then erectile dysfunction. These are all side effects of beta blockers. So coming to the next question. All of the following are contraindication of nitrates except presence of right ventricular MI, use of PDE5 inhibitors in the last 24 hours, HOCM, acute MR. Acute MR actually it's an indication of nitrates because it reduces the afterload. So the answer for this question is option 4. All are contraindications except acute MR. So we will discuss. So first we have to know the mechanism of nitrates. So in nitrates, it dilates arteries, it dilates veins and coronaries also. Arteries, veins and coronaries. It dilates coronary arteries. But more than 100 millimicrons. In contrast to this, there is another drug which we will discuss later, which is necorandil. It is a potassium channel opener. It dilates coronary vessels which are less than 100 millimicrons. So this is the first mechanism. Second mechanism dilates venous system. So decreases preload. It also decreases arterial system, decreasing afterload. So it dilates all vessels, arteries, veins, and coronary vessels. So this is used for termination of variant angina. This is Prince-Metal angina. Okay, these are the contraindication. So mainly we should not use whenever the patient is having low BP, less than 90 mmHg, or patient is having marked bradycardia or tachycardia. So whenever the patient is having right ventricular MI, he will be having decreased preload. Already you will having decreased preload. You have to not again decrease the preload by giving nitrates. So it causes profound hypotension. And a patient who have taken phosphodiesterase for erectile dysfunction within the last 24 hours. Whenever he is taking sildenafil or vardenafil, it is for 24 hours. Whenever he is taking tadalafil, which is long acting, the patient should not have nitrates, tadalafil, for 48 hours. So this is important. Before giving nitrates, this history should be asked. Whether he is taking any phosphodiesterase inhibitor, then HOCM. Again, HOCM, you should not decrease the preload and afterload. Then severe aortic stenosis. Our answer to this question is acute MR. Okay. Next we'll go. All of the following are true about ranolazine except. Okay. There is a mixed response to every options. So all are true about ranolazine except. So the correct answer to this question is option 3. Actually, it prolongs the QT interval. So I have written it shortens the QT interval. So mainly the ranolazine, all option is a reseller. It's a teaching MCQ. It is an inhibitor of late sodium influx. Late sodium influx. Next, it is used as antiarrhythmic. Sometimes it is used as antiarrhythmic for conversion of AF to normal sinus rhythm. So it is included. It is included as antiarrhythmic drug also. Actually, it prolongs the QT interval. Prolongs the QT interval. Then another mechanism of action is it reduces the HbA1c levels. So it is the preferred drug in diabetes patients. Preferred drug in diabetes patient with CAD because it reduces the HbA1c levels. So this ranolazine is available as a tablet form, and you can be used the ranolazine as a second line anti-anginals, not first line, 500 mg BD dose, and you can go up to 1 gram BD. So, but you have to be aware of the increasing QT interval, and then you have to monitor for the QT interval. It also does not decreases BP. It has a stable effect on the cardiac hemodynamics. In beta blockers, all the other things, it decreases the BP. It decreases the pulse rate, but this is a neutral anti-anginal. Yes. So coming to the other anti-anginals. So these are new anti-anginals which are added as a second line drug. When the first line drugs, after giving first line drugs, if it doesn't work, you can add these drugs, which is nicorandil, trimetazidine, and ranolazine. Ranolazine we already discussed. Trimetazidine, it is a metabolic modifier. It is the pathway of fatty acid oxidation inhibitor. So this also doesn't reduces any heart rate, reduces any BP. So it can be used as trimetazidine 35 mg BD dose. Next is nicorandil. So nicorandil, it has two mechanism of action. One mechanism of action is to late. It's not late. It is a potassium channel opener. Another mechanism is similar to nitrates. So in this, there is less hypotension. So in this patient, you can use nicorandil as a dose of 5 mg OD, 5 mg or 10 mg. So these are ardent drugs. The main side effect of nicorandil is mouth ulceration or gastric ulceration. So other than this, these drugs can be used as a second line drugs for angina. Okay. Next, same which I discussed for chronic coronary syndrome, we give single antiplatelets, statins, ACA, ARB if there is LV dysfunction or if there is patient is hypotension, and anti-anginals. Okay. We finished the stable ischemic heart disease. Next, we will move on to the non-ST elevation MI or unstable angina. So this pathophysiology is different. The three pathophysiologies there. One is plaque fissure with inflammation, plaque fissure without inflammation, and plaque erosion. Whereas in STEMI, there is a plaque rupture. But in NSTEMI, there is no 100% occlusion, and there will be a plaque fissure with or without inflammation with plaque erosion. So plaque erosion is present in 1/3 of patients of ACS. Okay. So whenever a patient comes with to you with this one, whether it's a cardiac chest pain, we have to divide into CCS or ACS. So whenever ACS, and again two classifications, STEMI or NSTEMI. In NSTEMI, again another subdivision is unstable angina. So whenever the TROP T is troponin test is negative with same cardiac chest pain, it is unstable angina. Whenever the TROP T is positive, it is NSTEMI. Same. The patient is having ST depression or T wave inversion with you have to do troponin. Troponin is negative, unstable angina. Then troponin is positive, NSTEMI. Whenever there is ST elevation, no need of doing troponin at all. Directly you have to treat the patient. It is STEMI. Other thing, chronic coronary syndrome, and other is non-cardiac chest pain, which is non-cardiac. So this is very important. Unstable angina, NSTEMI, STEMI. Okay. So very important is we all think that NSTEMI is STEMI is very dangerous. NSTEMI is it's benign. It's not like that. See, among patient with NSTEMI, 35% is having triple vessel disease. All three vessels will block. 20% is having double vessel disease, and 10% is having left main coronary artery. So if in STEMI, it is only one artery is blocked, whether it is anterior LMA, inferior LMA. But see, in NSTEMI, it is more dangerous than STEMI in long term. So 35% is having triple vessel disease, 20% is having double vessel disease, 10% left main, and 20% single vessel, and 15% is having no apparent epicardial coronary stenosis. So there is one term called MINOCA. MINOCA means myocardial infarction with non-obstructive coronaries. So when you do a CAG for this patient, there will not be any plaque. There will be less than 50% stenosis. Whenever there is more than 15%, it is significant. So then it may be due to microvascular dysfunction. It is also called as microvascular angina. Microvascular dysfunction. So this is very important. So this is most common in patients with diabetes who is having microvascular disease. So this is also called as cardiac syndrome X. So whenever you see a patient with cardiac chest pain, you do CAG, there is no obstruction, he only is having angina, then it may be a MINOCA. It may be a non-obstructive coronary due to microvascular angina. It is microvascular dysfunction. So NSTEMI is very important because it is having more deadly disease. Most patients we see with NSTEMI will have double vessel or triple vessel disease. Okay. We'll go to the next question. All of the following are included in the TIMI risk score for non-ST elevation ACS except. This TIMI risk score is given in Harrison. All of them are included in the TIMI risk score except use of clopidogrel in the last 7 days. Yes. So actually the answer for this question is use of aspirin. I have changed the option. It's use of. This is the answer. All others are included. Age more than 65 years, prior angina, and increased cardiac biomarkers. So we'll see the TIMI risk score. So this is the TIMI risk score. TIMI risk score, there are 7 points. One is age more than 65. Second is risk factors. Then known CAD. And this is our option. Aspirin used in the last 7 days. Then severe angina. Then ECG changes, whether STT changes, ST depression more than 0.5 millimeter, and positive cardiac biomarkers. Based on this, we put the score and we divide this into mild risk, moderate risk, and the severe risk. So this answer to this question is use of clopidogrel in the last 7 days. Okay. So whenever a patient comes with NSTEMI, the patient it's ACS, so it's not a chronic coronary syndrome. So patient will have rest pain. The pain will be more than 10 minutes. You will not have a classical angina. You will have rest angina. During rest only, you will be having pain. So which is lasting for more than 10 minutes. The patient will have a relative new onset pain within the prior 2 weeks. And it's a crescendo pattern. Normally, angina is a crescendo decrescendo. But in this patient, the chest pain will be gradually increasing. So whenever the patient is having these things, we have to suspect as ACS first. At least any one of these 3 features. Rest pain, new onset pain, and crescendo pain. So then we have to, after seeing this, we have to do a ECG. So in ECG, there is the non-ST elevation. It's not ST elevation. So there may be ST depression or T wave inversion. But it should be in 2 contiguous leads. Very important. So it should be here new horizontal or downsloping ST depression. Same as we read in stress ECG. It is not upsloping. New horizontal downsloping of more than 0.5 millimeter in 2 contiguous leads, with T wave inversion more than 1 millimeter in 2 contiguous leads. So it should be another ischemia pattern. It should be, if this is the ECG, it should be a symmetrical T wave inversion. So more than 1 millimeter with a symmetrical T wave inversion. For example, when a patient is having LVH with strain, he will also have a ST depression. But in that, there is a asymmetrical, its ECG will be like this. So there is, sorry, 1 second. This is ST depression. So patient will not have a significant, it will have like this and sudden upstroke. It will not be symmetrical. So, but in this, the patient will have symmetrical T wave inversion with more than 1 millimeter in 2 contiguous leads. Then ECG. Then after ECG, we have to go for troponin. Actually, we already discussed. Trop T negative, troponin is there. Trop T negative, it is unstable angina, and Trop T positive, it is NSTEMI. So whenever Trop T positive, Trop T can be positive due to a variety of reasons. So this is very important. It's not only positive in myocardial diseases. There are also non-cardiac causes of troponin rise. So very important is myocardial injury. This is all you know. Coronary artery spasm, coronary artery dissection. Even in hypotension, severe anemia, the troponin will be positive. Another main thing is in tachyarrhythmias and hypertension. If a patient comes with severe hypertension of 220 on 10, the patient troponin will be borderline positive. he will be having mild chest pain due to the increased wall stress. So it's not NSTEMI. So this is a patient after recovering from the VT, there will be some myocardial injury. That time TROP-D will be positive. So TROP-D positive doesn't means only it's due to MI. There may be a variety of reason other than MI. So you have to remember the cardiac causes. Then we'll go to non-cardiac causes. Tachyarrhythmia, hypertension, then severe anemia. Next, other conditions of is even in heart failure. Heart failure, patient will have troponin elevation. Another very important thing is pulmonary embolism. In pulmonary embolism, we grade the pulmonary embolism based on troponin positive only. So pulmonary embolism, it causes RV ischemia. So RV strain. So RV ischemia causes increase in cardiac troponin. Then myocarditis, Takotsubo syndrome. We discussed earlier class in cardiomyopathy class. So even defibrillator shock. Whenever we give a defibrillator shock, there will be mild myocardial injury, cardiac contusion, and after any ablation for SVT or VT, any they do a radio frequency ablation. At the time there will be a myocardial injury. So these are all cardiac causes of troponin rise. Even there are non-cardiac causes of troponin rise that we'll see. So other non-cardiac causes very important is chronic kidney disease. So chronic kidney disease, patient will have breathlessness, and he will be having uremic pericarditis. So uremic pericarditis is very common. That patient will come to you with breathlessness and chest pain. We think the patient has ACS, but ECG will be normal. And due to TROP-T will be positive. So at that time, you should not label the patient as NSTEMI. So this TROP-T may be false positive due to CKD because troponin cannot be excreted. Then sepsis, very important. Then stroke, any neurological damage also causes this one. Then pulmonary embolism, which I already discussed. Then chemotherapeutic agents, even strenuous physiological causes, strenuous exercise also causes increase in troponin. Another main cause is UGI bleed. UGI bleed also causes increase in troponin. So all this you should remember is to rule out troponin. It is called as troponitis. So you should not label if troponin positive, it is not MI. There are variety of reasons. Clinical context is very important. So ACS, in the case of whenever suspect a patient of chest pain in CKD, it may be due to uremic pericarditis also. But you should see other things, ECG, how is the quality of chest pain, all these things. So this is the ECG. You can see down sloping ST depression in more than 2 contiguous leads of more than 0.5 millimeter. So this is very important. You can see actually your ST depression is 1, 2, 3, 4, 5, 6. It's more than 8 leads. Whenever the patient is having ST depression more than 8 leads, and you can see here, you can see the ST elevation in AVR. So very important is ST elevation in AVR with ST depression in more than 8 leads. It is left main LMCA pattern. It's very important. You can localize this ST depression, other ST depression, it is localized to LMCA, left main coronary artery occlusion. So in this patient, it is emergency. You should take for coronary angiogram and see for LMCA lesion. This is a LMCA pattern. Okay. Next question. It's a very much practical question. Recent guidelines from EAC. 75-year-old male, acute chest pain for 4 hours duration. ECG shows new onset ST depression in V1 to V4 with Grace risk score of more than 140. He needs to be taken to a PCI. When we will do a PCI? 2 hours, within 24 hours, within 48 hours, within 12 hours. Very good. Most of you answered correctly. So there is a risk score, Grace risk score. Based on this, we decide whether the patient need to be taken to a cath immediate CAG or not. So most of you answered the answer as option 2. So this is the answer. So we will discuss that when a patient comes with STEMI, the treatment algorithm is different. Whenever a patient comes with NSTEMI, this is also different. We'll discuss when we'll do PCA. So next slide is see. Whenever a patient comes to with NSTEMI diagnosis, whenever we have to see these things. These are the risk categories. We have to risk stratify: very high risk, and low risk. So first we will see about very high risk. So very high risk everyone knows. So very high risk means he is having BP, hemodynamic instability, he is having refractory chest pain, then he is having any arrhythmias and mechanical complications, and then ST depression more than 1 millimeter in 6 leads. So which LMCA pattern, ST depression more than 1 millimeter in 6 leads plus ST7 elevation in AVR or V1. This LMC pattern. These are very high risk categories, which needs to be we have to take to the cath lab within 2 hours. So it is less than 2 hours. It is immediate invasive. So in these patients, we have to do cath lab within 2 hours. Next category is early invasive. Early invasive, which was the question discussed before. It means which is a Grace risk score. Which is a Grace risk score. You can read about Grace risk score. So it is whenever it is more than 140. Then it is whenever a patient, same patient, he is established NSTEMI diagnosis. If he is top T positive, is NSTEMI. So then established NSTEMI diagnosis, dynamic changes, reset cardiac arrest without ST7 elevation or cardiogenic shock. So all these patients should be taken to the cath lab within 24 hours. So all other patients you can plan whether you can plan for invasive. Whenever is a very low risk, you can plan for selective invasive strategy. So this is our Grace score was more than 140. So we have to take him to the PCI within 24 hours. So this is the recent EAC guidelines, 2020 EAC guidelines. Okay, must have answered correctly. Very good. So next, same. We have discussed about NSTEMI anti-ischemia treatment. The same. We can you can give nitrates, beta blockers, calcium channel blockers. Morphine can be given. Morphine can be given whenever there is severe pain and whenever the patient is refractory to nitrates. But one of the problems with morphine is it interferes with the absorption of clopidogrel. So at that time, the clopidogrel action is delayed. So it is you have to give only when it is absolutely necessary. So you should not use routine morphine to all patients with STEMI or NSTEMI. It interferes with the absorption of clopidogrel. You can give morphine slow IV 4 mg IV slowly. You can give 1 to 2 repeated 1 to 2 doses. Okay. So this already we discussed beta blockers, calcium channel blockers, and morphine. This is morphine, which is morphine you can give whenever it is despite 3 sublingual nitrate tablets, recurrent ischemia. So it also has side effects: hypotension, respiratory depression, confusion, all these things. Okay. So next, we give anti-ischemic acute treatment for pain. Next, we have to treat the patient with antiplatelets and antithrombotic regimens. So we will discuss about the antithrombotic regimens. So antithrombotic regimen. So before discussing it with the antithrombotic regimen, we will see how we will treat the patient with whenever a patient comes to us with ACS NSTEMI, we should not routinely give a P2I12 inhibitor. This is very important because first whenever a patient comes with STEMI, we give loading dose of all 3 drugs: aspirin plus P2I12 inhibitor plus statins. But in NSTEMI, the guidelines have changed. You have to give primarily aspirin plus statins. You should not routinely give a P2I12 inhibitor. Very important. It is see here. Based on the evidence, it is not recommended to administer pre-treatment with P2I12 inhibitors in whom coronary anatomy is not known. Whenever we have to do a CAG, you have to know the coronary anatomy and then you have to give other drugs, which is clopidogrel, prasugrel, other things. Because whenever a patient, I told you, whenever a patient with ACS will have a triple vessel disease, you will have a unfavored anatomy. So whenever you do a CAG and you see a triple vessel disease, which is not amenable to PCI, you have to do CABG. So at that time, if you give a P2I12 inhibitors, you have to delay the surgery for 5 to 7 days based on the drugs. So based on this, you should give aspirin and statins. You have to see the coronary anatomy. After seeing coronary anatomy, you can give P2I12 inhibitor. So this is very important. This is a new recommendation. Based on the available evidence, it is not recommended to administer P2I12 inhibitors unless knowing coronary anatomy. So, but when you are planning for delayed invasive treatment, you can give P2I12 inhibitors. So, but whenever you are planning for CAG, you know the coronary anatomy and then give clopidogrel, prasugrel, or ticagrelor. So this is the reason why. Okay. Then antiplatelets. So antiplatelets, same antiplatelets we discussed. Loading dose followed by aspirin. Then you see coronary anatomy. Then you will give clopidogrel, prasugrel, or ticagrelor. That we will discuss. Then anticoagulants. So anticoagulants you can give whether UFH or enoxaparin. Enoxaparin or fondaparinux. Okay. Further we will discuss. Next question. All are true about P2I12 inhibitors except. This poll will end in 15 seconds because we have a lot more to cover. Dose modification required in renal failure. Onset of ticagrelor is 0.5 to 2 hours. Clopidogrel and prasugrel are prodrugs. Prasugrel 5 mg per day for patients aged more than 75 years or with body weight less than 60 kg. So there is 50-50 answer for option 1 and option 3. Okay. So the correct answer is all are true about P2Y12 inhibitors except. So the onset of ticagrelor is 0.5 to 2 hours. This is correct. So then for these are prodrugs. Then prasugrel normal dose is 10 mg per day. But whenever a patient is more than 75 years or with body weight of you give 5 mg. Dose modification is not required in renal failure. So you can give all drugs, prasugrel, clopidogrel and ticagrelor in full doses in renal failure. So the correct option is option 1. So we'll discuss. So this is this one, clopidogrel and prasugrel are prodrugs. See, then ticagrelor. Ticagrelor is a reversible inhibitor and the onset of action is 0.5 to 2 hours. This also prasugrel also onset action is 0.5 to 4 hours. Whenever a patient, if you didn't give any P2Y12 inhibitors, prior to PCA, immediately you can give cangrelor prior to PCA because the onset of action is only 2 minutes. You can give cangrelor and take for PCA. But all these drugs you should wait for at least half an hour to 4 hours and half an hour to 2 hours. Then delayed surgery for clopidogrel and ticagrelor it is 5 days. For prasugrel it is 7 days. See another decision. Kidney failure, no dose adjustment is required for any of these drugs. So very important is. So then whenever a patient comes with NSTEMI, what you will do? You will give anticoagulation. You will do PCA. If there is any stent ablation, you do stent for that lesion. And whenever a patient, you stent the patient whenever you stent the patient, you give dual antiplatelet therapy for 1 year. It's very important. See here, most common treatment. All this is complicated. Whenever the patient is requires PCI after the any NSTEMI or STEMI, you give antiplatelets for 12 months. Later, then you can decide based on the ischemia risk or bleeding risk. So in for whenever after 1 year, you can plan for a single antiplatelet, and if the patient is having a high risk, you can plan for other things. Like for example, you can use dual pathway inhibition, means you can give aspirin antiplatelet with rivaroxaban. This is now upcoming this one. So rivaroxaban is an anticoagulant. You can use it in MI patients who have high risk of thrombosis, but at low dose. Rivaroxaban 2.5 mg BD. Normally we use the patient rivaroxaban of 15 mg or 20 mg. But in this you can use two slow dose 2.5 mg. It's a vascular dose of rivaroxaban. So you have to give DAPT for 1 year followed by single antiplatelet. So this you have to remember. This all you can go through when you have time. Okay. Another you have heard about GP2B3A inhibitor, apiximab, tirofiban, eptifibatide. All the tricks are not used nowadays, but you can use. There is a specific indication you can consider as a bailout. For example, if this is the lesion, you stent the lesion with stent, but there is no flow after stenting also. At the time you can give infusion of this one tirofiban or apiximab or eptifibatide. So this is the only one indication. It should be considered as a bailout if there is evidence of no reflow or thrombotic complication. Next, already we discussed this question. Whenever a patient is having AF, we should not use other drugs other than clopidogrel. Actually, this was our last, which we discussed in the last class. See this one. Whenever a patient is AF is undergoing PCI, the patient will be having requirement for 3 drugs. So means patient will be having a requirement of anticoagulant plus DAPT. So this was a question also in the last class. So in this patient, we'll discuss this also. So whenever the patient is having undergoing AF patient is undergoing PCI, we have to give triple drugs, which means dual antiplatelet plus no oral anticoagulant. that DAPT, which is aspirin, you can use another drug. The P2Y12 inhibitor must be a clopidogrel. This was the last this one. Clopidogrel is a preferred P2Y12 inhibitor of choice in patients with PCA with atrial fibrillation. So you can give triple drugs. Then following that, you have to see for off for 1 month. Then you have to give double therapy, which is Novax plus single antiplatelet. Then further you have to give only Novax. This remember this, right? We have to give triple antiplatelets. Then further you have to give double therapy for 1 month to 1 year, and then only Novax. Okay. Next question. 55-year-old male post CABG 2 years back on rosuvastatin high intensity 40 mg OD. At present, is total cholesterol is 250, LDL is 110, triglyceride is 200. Which of the drug will give next? So the patient is on high dose rosuvastatin. So it is next to drug you have to prefer with estimate. This is very important. So whenever the LDL goal for patient with ACS or LDL goal is 55. So but here LDL is 110. It is 2 times higher than normal. So what happens whenever a patient with the ACS or any ischemic heart disease comes to you, you have to give high intensity statins. Patient has not achieved LDL goal, which is 55 in case of ACS, not achieved LDL goal. Then second line of drug is, it is not PCSK9 inhibitor, it is ezetimibe. It is 10 mg OD. So whenever after the ezetimibe, still patient is not having achieved the LDL goal, not achieved, then you have to go for PCSK9 inhibitor. This is aliricumab or evolocumab. So this is the recent guidelines. So whenever the patient is not, whenever a patient with ACS comes to you in follow-up after 2 years, any ACS, post CABG or post PCI, you have to see for LDL. LDL, you have to maintain the LDL goal within this. If not achieved, you have to add second drug. Not for now, you should not add in fibrates. No, nothing is there. You have to add ezetimibe second line. Third line drug, if not controlled, is PCSK9 inhibitors. So now new drug has came. Which I will tell you the mechanism of action. Can anyone name the drug? Which is ATP citrate lyase inhibitor. This was the question in recent INICET also. This is a new drug. Very good. It is a bempedoic acid. So bempedoic acid is ATP citrate lyase inhibitor, which is the step prior to statin, before HMG coil reductase. Very good. Okay. Next, we will go to the Prince metal angina. So all are true about vasospastic angina except. We will end the poll in 20 seconds due to. You can give a try. One person have answered. It is phosphodil is a Rho kinase inhibitor that has shown to inhibit acetylcholine induced spasm. Okay, we will discuss. So all are true about vasospastic angina. All options are true. We will see first we will come from down. Non-sedative beta blockers such as propranolol, lastly we discussed. Exacerbate vasospasm should be avoided. So this is true option. Then phosphodil. Phosphodil is a new drug. It's a Rho kinase inhibitor which has been shown to inhibit acetylcholine induced spasm. We can use as a second line drugs for Prince metal angina. This is also correct. Again, the triggers for vasospastic angina, magnesium deficiency. There are many triggers: cocaine, amphetamine, and we have previously discussed the one anti-cancer drug. Can anyone name which causes vasospastic angina, which we discussed in the previous class? Okay, due to lack of time, I'm already telling it is 5-fluorouracil. Okay, so magnesium deficiency is a trigger for vasospastic angina. So the first option is common in postmenopausal females. No, this is the false option. So it is common in males first. Second, it is common in young population. It doesn't go to postmenopausal females are they are risk factor for ischemic heart disease, coronary artery disease. So it is common in young males, which whenever the risk factor is less, only one predominant risk factor, smoking. Patient will be having only smoking, he will be young patient. That patient will have trigger for vasospastic angina. So the answer for this question is option 1. Next question. Which of the following is not a provocative agent for Prince metal angina? Which is not a provocative agent for Prince metal angina. All other things are provocative things. We will give intracoronary ergonovine, intracoronary acetylcholine, or hyperventilation. All this can precipitate Prince metal angina. Adenosine is not a provocative agent. It's not a provocative agent for Prince metal angina. The answer for this question is adenosine. This is a recent NEET SS question. Okay. Vasospastic angina, it is the mechanism is it is in name only. It is a focal or diffuse spasm. It is due to hyperreactivity of the vascular smooth muscle. So this hyperreactivity is due to the hyperreactivity is a mechanism for Prince metal angina, and other mechanisms are autonomic nervous system dysfunction and endothelial dysfunction. So these are the features specific to vasospastic angina. So it occurs at rest. So it is called as rest angina, and at night occur from midnight to early morning. So effort and actually patient during walking and during it's not like typical angina. Exercise tolerance is preserved. So it is it lasts for 5 to 15 minutes. Then hyperventilation, we already last option was system. It can precipitate vasospastic angina. There is a criteria for this. This we will discuss. So this is a vasospastic angina diagnostic criteria. 3 points: nitrate responsive angina. Because I told the first line treatment is nitrate. Second and beta and calcium channel blockers. Sorry, not beta blockers. Beta blockers are contraindicated. Second is transient ischemic ECG changes, then coronary artery spasm. See, nitrate responsive angina, very important is rest angina, diurnal variation in night, early morning or night, reduced in morning. Then hyperventilation can precipitate an episode. Calcium channel occur, suppresses episode. Then you can have ECG changes. It can have ST elevation or ST depression. Then coronary artery spasm can be spontaneous or it can be induced by acetylcholine or ergonovin, which is ergotyl chloride. So this is the diagnostic criteria for vasospastic angina. Treatment first is for whenever a patient has an attack, you can give nitrates, sorbitrate or glycerol trinitrate. Then mainstay of treatment is calcium channel blockers. See here the calcium channel blockers we use are this one, diltiazem 240 to 360 mg we can give, or amlodipine 5 mg 10 mg. Next phosphodil, we discussed it is a Rho kinase inhibitor. And statins also have some role because there is endothelial dysfunction is the main pathogenesis. So endothelial dysfunction is corrected by statins. Okay. Then next coming to the most important part, which is STEMI. This is the you have to know every points, and recent guidelines also changed. We will discuss. So the pathophysiology is we discussed earlier the plaque fissure with or without inflammation and plaque erosion in STEMI. But here it is a plaque rupture. The plaque is ruptured, and this is the already the patient will having atherosclerosis. There may be some this one, and the plaque is ruptured, and this high thrombogenic material is exposed, and there is a platelet plug first formed. In this platelet plug, finally fibrin gets entangled, and finally there is 100% occlusion. So this thrombus is formed. First platelet monolayer, then finally fibrin strands. So this is the pathophysiology. So this whenever you see patient of STEMI, he will be very anxious, very agitated, severe pain will be there. It is more than 30 minutes. It will cluster. You can see many patients in the early morning, they will come, there is clusters in the fear of awakening. The presentation will be at early morning times. So it's usually more severe and last longer. And very important, this one, anterior infraction will have sympathetic nervous system activation. So we'll have tachycardia and hypertension. But inferior wall will have parasympathetic and will have opposite, bradycardia and hypotension. Okay, then you can see pericardial friction rub. You should be keep on auscultating. It is very evanescent rub. It will be for 1 hour. 1 hour it will be there. After the next hour it will not be there. So it will be heard in patient transmural STEMI at sometimes. And if you are examined frequently, you have to examine it frequently. Okay, so ECG. The ECG criteria is there for diagnosing STEMI. That we will discuss. So very important is this is the STEMI criteria. All leads 1 millimeter. You can remember all leads 1 millimeter except V2 and V3. Because in V2 and V3 there is a normally slight ST elevation. In this we divide into males, females. Where you see females is 1.5 millimeter. That's all. In males also less than 40 years and more than less than 40 years and more than 40 years. In less than 40 years, we have to keep little slight high ST elevation, which is 2.5 millimeter. And in more than 40 years, it is 2 millimeter. So very easy. All other leads 1 millimeter. In V2, V3, females 1.5 millimeter. In males, less than 42.5 millimeter, more than 42 millimeter. This is the STEMI criteria. And another thing, in posterior wall MI, it is not 1 millimeter, it is 0.5 millimeter. Because posterior wall MI is so much muscle is there. Muscle, the ECG can't record that much ST elevation. So see ST elevation, accordingly lead V1, V7, V6, V7 and V9 should be considered posterior wall MI. Okay, another thing, whenever you see a posterior wall MI, what happens is there will be ST depression in V1 to V4. This is very important because it is a mirror image. Anterior LMI ST depression means it's a posterior LMI ST elevation. So whenever you will see a patient with ST depression in V1 to V4, first you have to suspect posterior LMI. Then you have to take posterior leads V7, V2, V9. Okay. All are causes of ST elevation ECG except. Very good. Most of them answer correctly. You can try. It is all of their causes of ST elevation except it is not hyperthermia, it is hypothermia. So the answer to this question is option this one. It is so hypothermia. So main thing is not all ST elevations are MI. This is very you have to remember this thing. Not all ST elevations are MI because there are many causes of ST elevation which is not MI. So we will discuss this one. So ST elevation can be normal, which we told in V2, V3. So a normal V2, V3 there is it's called male pattern. In V2, V3 is there. Then early repolarization. You can see many patients of early repolarization will have ST elevation, and we suspect them as MI. There will be bradycardia with some. There will be some notch slurring, notching at the J point. Next, ST elevation can be of LVH, left ventricular hypertrophy, and left bundle branch block. So then next you can see for acute pericarditis. After acute pericarditis, you will have diffuse ST elevation, but there will be reciprocal ST depression in AVR. And another thing is PR segment depression. So whenever there is PR segment depression with ST elevation in all leads, you should suspect of this one acute pericarditis. So another thing is LV aneurysm. Whenever there is a persistent ST elevation, whenever you lyse the patient, after that also patient is having ST elevation, you should suspect LV aneurysm. This is the cause of persistent ST elevation. Next, hyperkalemia can also cause. Then next, Brugada syndrome. Brugada syndrome is a coving ST elevation in V1, V2, right side leads. Pulmonary embolism. Pulmonary embolism can also mimic MI. It can cause ST elevation in the inferior leads due to RV ischemia. Then after cardioversion, after when a patient gets cardiac arrest, there will be pulseless VT and you do cardioversion. At the time, it can be ST elevation, but it doesn't last for longer time. It lasts for a minute after DC shock. Then already we discussed, which is Prince metal angina. And another thing here, this option is you can see intracranial hemorrhage. Even intracranial hemorrhage, it causes repolarization abnormalities and it causes ST elevation. And you can see that this is a cerebral T wave. This is called as, it's a deep T wave, which is broad cerebral T wave, which happens in case of subarachnoid hemorrhage. That's that one. It is not due to any ischemia. It is a cerebral T wave, which is very, very deep and wide. It is due to repolarization abnormality. So this is the other causes of ST elevation. Okay, 16-year-old female with BP 90/40 on inotropes and heart rate of 140. ECG is taken, shows following changes. Which of the following is likely? I'll show you the ECG. Before that, the options are neurogenic. Ankur, you can open the polls. Neurogenic myocardial stenting, critical illness ST elevation, acute subocardiomyopathy, extensive anteriotomy. So this is the question. 16-year female, low BP, heart rate 140. ECG is taken and shows following changes. So this is the options and this is the ECG. Neurogenic myocardial stenting, critical illness ST elevation, acute subocardiomyopathy, extensive anteriotomy. So this is the ECG and these are the options. Okay, very good. One of you answered correctly. It is critical illness ST elevation. It can't be extension anteriotomy because it is patient is only 16-year female. She can't have any risk factors for MI. See, this is patient is in low BP. She's in she's in shock. It may be septic shock. So here it is not ST elevation. Is not classic ST elevation. See, it looks. This is called critical illness ST elevation. Otherwise, it is called as spiked helmet sign. See, this resembles the spiked helmet, which is a German military helmet. So this is the recent initiate MCQ. So you can see the resemblance of this. It's called a spiked helmet sign. It occurs in critical illness spiked helmets in SHS. So this you can see this resemblance of ST elevation like this. So same. So this is the answer for this question is critical ST elevation, critical illness ST elevation. So this is important entity. It is called a spiked helmet sign. It is a high risk of mortality. It is associated with critical illness. Anything you can happen. Patient is having sepsis. Patient is having abdominal perforation. So many theories have been proposed to this cause. Most important theories due to the high intrathoracic pressure. There is high intrathoracic pressure and diaphragm comes in contact with the inferior wall often and it causes repolarization in the inferior wall. So there will be most commonly ST elevation in the inferior leads. So it's not a proven, but this hypothesis, inferior leads, that spiked element will be in the inferior leads. Other explanation is due to the adrenergically mediated prolongation of repolarization. So only whenever the patient is in ill septic shock, when a patient is perforated, there is be an increased sympathetic activity, it will prolong repolarization. So this is very important initial MCQ. The answer is critical illness ST elevation. Okay. So troponin is very important. It remains elevated up to 7 to 10 days after STEMI. But CKMB, it's not like that. It rises within 4 to 8 hours and it returns to normal by 48 to 72 hours. So first they were using as a marker for reinfraction. But now reinfraction, even for patient with reinfraction, if the patient is having acute MI, you thrombolize the patient and after again 24 hours he's having same chest pain. After 24 hours or you take 48 hours. After 48 hours he's having same chest pain and you see ECG there is some STT changes and you again you can't do troponin because troponin will be elevated. That was the prior concept, but now even in reinfraction you have to see for troponin. You have to see the elevation in troponin from the previous this one. More than 20% elevation is significant. So CKMB is not seen. You have to again in reinfraction the investigation of choice is troponin. So because at CKMB is not it has so but this CKMB the total CK is not this one specific because it is elevated in skeletal muscle disease, trauma, other things and all. Okay. So whenever a patient with STEMI, you confirm with ECG and echo you should see for all these things: regional wall motion abnormality, LV function, and mainly we see in ICU is mechanical complication because mechanical complication this PCI revascularization takes a backseat. PCI takes a backseat. You have to directly go for a surgery. We'll discuss about mechanical complication of STEMI. So PCI takes a backseat. Okay. A 55-year-old male seen post CABG 1 day back, presents with chest pain in the ICU and ECG shows ST depression. A troponin value is 1.3. Which of the following type of MI the patient belongs to? Ankur, you can open the polls. We'll in only 15 seconds for this question. Very good. Most of them answered correctly. There is equal option for type 2 and type 5. Okay, we are ending the polls due to lack of time. The most answered is type 2 MI. So we will discuss it. Actually, it is a CABG rated MI, which is type 5 MI. It's a type 5 MI. The answer for this question is type 5 MI. So we will discuss the types of MI based on the UDMI, universal definition of MI criteria. So you can see type 1 MI and type 2 MI. Type 1 MI is all MI you see in the which you see daily, which is due to atherothrombosis, which is due to atherothrombotic event. Then type 2 MI, which you see in the ICUs, normal ICU with patient is critical illness, patient is having sepsis. So it is due to the oxygen supply demand mismatch. There is no any plaque. It is due to severe anemia. It is due to any hypotension without plaque erosion or rupture. See, anemia, spasm or shock, all this thing. This type 1, type 2. Then type 3. Whenever a patient comes to the ICU, comes to the emergency, he is having some ECG changes for STEMI or he is having any arrhythmias, and the patient suddenly collapses. Your trop T is before you take trop T, the death occurs before these blood samples have been obtained. This is type 3 MI. Sudden cardiac death with new onset ischemic changes, any ischemic changes, ST depression, with symptoms suggestive of myocardial ischemia, and the death occurs before blood sample has been drawn. This is type 3 MI. Then we will go for type 4 MI. So in type 4, there are 3 types. So type 4A, 4B, 4C. 4A means when you are doing a PCI, if patient develops CAG and PCI, patient develops MI. This is PCI related MI. In this, troponin elevation should be 5 times more. Why I am telling is, in CABG rated MI, the tropo elevation should be 10 times more. So type 4A is due to PCI related MI. Type 4B is due to after you put a stent, the patient can develop a stent. In stent, there may be a thrombus. So it is 4BMI. So in some cases of 4CMI, you have put the stent. So what happens? Inside the stent, there will be a proliferation of this smooth muscle cells, all this, and it can cause further instant restenosis. It is called as ISR. You would have seen the CAG reports. I said ISR of LAD stent. So means it is instant restenosis. This is type 4 CMI. After the stent is not reapproached well, and after some 1 year, it can become restenosis. So main importance one, type 1 MI is due to atherothrombosis. Type 2 MI is due to demand supply mismatch. Type 3 MI, the patient has died before biomarkers obtained. Type 4 is PCI, type 5 is CABG. In 4, it is PCI related directly to whenever doing PCI, and type 4B, whenever you put the stent, after that it gets occluded, and type 4C, it is instant restenosis. Type 5, it is CABG related MI. So the top T elevation is important, 10 times, and it is 5 times. So our before this, you have done CABG 1 day back. He presents with again chest pain. You see some special changes, and top T is elevated. This MI is type 5 MI. Okay. So again, management same. Initial management, you have to give oxygen. Oxygen we can give only when not every patient should give oxygen. When your SpO2 is less than 90%, then you have to give loading dose, and you have to control the discomfort. Okay, the dose of the loading dose of the dose of prostacyclin acute MI is 2. You are confused with that 60 mg followed by 10 mg BD. Okay, we will discuss. The correct answer to this question, the dose of prostacyclin in acute MI, the dosage is you have to give 60 mg loading dose followed by 10 mg OD. This is the answer. We will discuss in the detail. Next, all are false about ticagrelor in ACS except. You should see the question. All are false. So we will discuss this question. So the maintenance dose of ticagrelor is not 90 mg OD. It is 90 mg BD. So the most common side effect of ticagrelor is dyspnea. Correct. Most patients with ticagrelor will come after you do PCI, will come with dyspnea. We think that patient has developed acute pulmonary edema. Further, when you see patient will have not any CREPS. So the most common side effect is dyspnea. It is a troublesome side effect. It is due to adenosine mediated. So whenever the you can it's adenosine mediated treatment, you can give derifrim for these patients. Some no need to change immediately. You can it will occur immediately after ticagrelor initiation. Also, you can give derifrim. After that, he will settle sometime. So then it is not a irreversible. It's a reversible. Dose adjustment is not required. So this is the answer. Is most common side effect is dyspnea. This is a true statement. So we will discuss. See, this is the loading dose of all the drugs. So first one, whenever a patient comes to you with any acute MI, you load the patient with aspirin 300 mg, followed by 75 mg OD. Actually, we think we have to give 150 mg. No, 75 mg dose is equivalent efficiency as of 150 mg, and it has less side effects also, the bleeding. Then clopidogrel again 300 mg. Whenever the patient is not taken for PCI, whenever the patient is taken for percutaneous coronary intervention, you have to give 600 mg. That is very important. And then what happens whenever the patient is more than 75 years, no loading dose for clopidogrel, you should give only 75 mg. All this you have to remember. So what happens, whenever a patient comes to the ICU, we give clopidogrel 300 mg, we do SK lysis. So next day when we take for PCI, we give another 300 mg because the loading dose is 600 mg. So more than 75 years, no loading dose for clopidogrel. Then prostacyclin 60 mg loading dose followed by 10 mg. So this is also OD. This is also 10 mg OD. Ticagrelor 180 mg followed by 90 mg BD. So all this you have to remember. These are the doses given. Patient with ACS, ECG is given. All of the all of the following are true except. See this ECG, ST elevations are there. We'll go to the option. Ankur, you can open the polls. So restriction of fluids, primary PCI, thrombolysis, antiplatelets. So this is ACS. All of the following are true except. This is the ECG. This is the ST elevation, and this is the option. Restriction of fluids, primary PCI. The most of answer it is the answer primary PCI. So see the question. See this ECG. This ACS is there. Patient is having inferior LMI. Inferior MI plus RVMI. So he's having a V1 ST elevation. So the patient is having mainly inferior wall plus RVMI. So patient is having decreased preload. So all of the following you should give. You should do PCI or thrombolysis. If you have your PCI capable center, do PCI or thrombolysis. You should give antiplatelets. You should not restrict fluid. You should give plenty of fluids to the patient because there is a decreased preload. If you restrict the fluids, then patient will go to further hypotension. Okay. The option 1. 75-year-old male brought to the casualty, history of chest pain for 30 minutes, and you take the ECG, shows STEMI, and the PCA capable center is very far away from the hospital. What would you do next? So very good. Most of you answer correctly. We will discuss this one. So 75-year-old male, chest pain for 30 minutes, ECG shows STEMI. PCA capable center is very far. So what you will do next? It's obvious. You can't wait the patient to transfer to PCA hospital. You can't do rescue PCA because we will discuss what is rescue PCA. You can't give anticoagulants. You should do fibrinolysis because it's STEMI and within window period. See, this is the very important slide. Whenever the patient comes to you with STEMI diagnosis, it's very important. You have to see whether you are a PCI center or non-PCI center. Whenever you are a PCI center, don't do fibrinolysis. This is it very important. Whenever a patient comes to you, enters into the door, you have to diagnose STEMI within 10 minutes. So less than 10 minutes, you diagnose STEMI. Then primary PCI within 60 minutes. So all these numbers have changed. Within 60 minutes, you have to cross the lesion. You should cross the lesion with the wire. So whenever a patient comes to the PCI capable center, directly transfer the patient to the catheter and cross the wire before 60 minutes. Your diagnosis is 10 minutes and then the 60 minutes. So whenever the patient comes to a regular hospital, non-PCI center, you see whether you can transfer the patient to a PCI capable center or not. Whenever the patient PCI capable center is more than 120 minutes, you should not waste the time. You should do fibrinolysis strategy with most probably bolus fibrinolytics. We will discuss which is bolus fibrinolytics within 10 minutes, less than 10 minutes. Whenever the patient is having a PCI nearby, you can transfer the patient within 1 hour, within half an hour, not 1 hour, within 30 minutes, you can transfer the patient. So from here to here, you transfer the patient within 30 minutes and then directly goes to the catheter and then here another 90 minutes to cross the wire. So here, whenever the patient is near to PCI center, when you can do the procedure within 120 minutes. It's not time to transfer. You have to transfer within 30 minutes and you have to cross the wire within 90 minutes. The total time is 120 minutes, not the total transfer time. Transfer time is 30 minutes, 90 minutes for crossing the wire. So total is 120 minutes. So whenever it is more than 120 minutes, you should not waste the time. You should do fibrinolysis. So this answer is do fibrinolysis. You should not transfer to the PCI hospital, which is very far. Very good. Next we will see most common whenever a patient is having up to 12 hours, both is efficient, fibrinolysis and primary PCI. But first you should prefer primary PCI because fibrinolysis has bleeding complication, other things. Primary PCI is best. So more than 12 hours, always PCI, primary PCI. Primary PCI is the best. After more than 12 hours, don't do fibrinolysis. Next, in cardiogenic shock, patient comes to any time. You should do primary PCI only. If the patient is having hemodynamic instability or arrhythmias, you should do primary PCI. So our window period for STEMI is 12 hours. Before 12 hours only, you can do thrombolysis. More than 12 hours, you should do primary PCI only. All of the following are false about fibrinolysis except. Okay, most of you answered correctly. So all of the following are false about fibrinolysis except. So this is the answer for this question is option 3. We'll discuss this detailing. Streptokinase it's not a fibrin specific, it is a non-specific agent. And reteplase, it's not given as a single weight-based regimen. It is given as 2 doses, 10 mg IV, followed by after 30 minutes. Sorry, 10 units IV. Or after 20 minutes, you give another 10 units. Okay. This is tenactiplase. Tenactiplase only given 0.5 mg per kg. So these trials have shown that rate of intracranial hemorrhage with tenactiplase or reteplase are higher than with streptokinase. This is very important. Streptokinase has less intracranial bleed, but other bleed is high with streptokinase. It should be administered within 24 hours. No, it should be administered within 12 hours of symptom onset. So our answer is option 3. See, these are the doses. You have to remember, very important. Everyone would have experienced streptokinase 1.5 million units over 30 to 60 minutes. We most on reteplase, it's a 10 units given. See, it's units, not mg. 10 units bolus given 30 minutes apart, and tenactiplase is a weight-based dose. You can give 0.5 mg per kg. It is a direct single dose. It is direct shot. So whenever it's more than 75 years in tenactiplase, you give off the dose. Based on the weight, you calculate and off the dose. And another altiplase, you can read the dose. All are absolute contraindication for fibrinolysis except. You should know what is absolute contraindication, which is relative contraindication. One of you answered correctly. So all are absolute contraindication except. So I see major surgery more than 2 weeks, more than 3 weeks. Actually, major surgery less than 3 weeks is a relative contraindication. So I have made this more than. This is not a contraindication only. It's major surgery less than 3 weeks is a relative contraindication. Previous SKUs within the last 6 months is an absolute contraindication. This is also very important. Severe uncontrolled hypertension, unresponsive to emergency therapy. You are giving any drugs, NTG, but the patient BP is not reducing. It's a absolute contraindication. Next aspect, aortic dissection. See, we'll see this chart. We have to remember very important. We remember mostly CNS, all CNS intracranial hemorrhage. Then ischemic stroke within 3 months. Next, but except ischemic stroke within 4.5 hours, because if the patient is having ischemic stroke, you can lyse the thrombus in the brain and in the heart whenever it is 4.5 hours. Next, all brain things, known structural cerebral vascular lesion, known malignant intracranial neoplasm. See, facial trauma within 3 months, or say surgery within 2 months. So all these are related to CNS. You have to remember all 6 things related to CNS. Next, see here, severe uncontrolled hypertension, unresponsive to emergency therapy. This is very important. Whenever the patient is having BP of 190, you don't tell, I will not lyse. You reduce the BP. If the BP is reducing, then you lyse the patient. For streptokinase, previous treatment within 6 months is absolute contraindication. Next, suspected aortic dissection. So these are absolute contraindication. Then relative contraindications are other things. So history of poorly controlled hypertension is relative contraindication. Significant hypertension at initial evolution. It is more, you can reduce the BP and lyse. History of more than 3 months. You can take high risk consent and lyse this patient. There is risk of bleed. Then other things which are not covered in absolute contraindications. And major surgery, this will be discussed. Major surgery less than 3 weeks and recent internal bleeding. This is very important. Again, pregnancy is a relative contraindication. So the answer to this question is major surgery more than 3 weeks. This and all you can go through in your time. Next, anticoagulant doses, very important. The anticoagulant doses which we give is, whenever we should give any anticoagulant, enoxaparin for example, we have to give until the patient is getting stent. Once the stent you put, you have to stop until the patient is getting PCA. See, until the patient is having, until revascularization or hospital discharge. Whenever you're not doing hospital, whenever you're not doing stenting, you are admitting the patient and giving SK only until hospital discharge or for a maximum of 8 days. This is very important. Enoxaparin you have to give until the patient is having revascularization or up to 8 days if you're not revascularizing. So these are the dose. We give 60 mg BD, but we forget this dose. When our patient is less than 75 years, we have to give 30 mg IV bolus first, followed by this one. This we give regularly. In motion more than 75 years, you should not give IV bolus. Then not 1 mg per kg, it is 0.75 mg per kg. Next, UFH and fondoparinox. Okay, 75-year-old male, acute anterior cardiogenic shock, coronary angiogram shows tubular vessel disease. what will you do next? Stenting of culprit infracranial artery, stenting of all lesions. Ankur, you can open the pulse. Fibrinolysis, OMT. OMT is optimal medical treatment. It's very important question, and it's also recently asked question. So it is equal options are there for all four. We will discuss this one. Due to lack of time, I'm ending the polls. Okay, this one 75-year-old male presents with acute anterior MI and cardiogenic shock. Whenever the patient is in cardiogenic shock, based on the culprit shock trial, there is one trial, culprit shock trial. Even if the patient is having all three vessels significant, you have to stent only the infracranial culprit IRA. For example, patient is having anterior MI, you have to stent only LAD. You don't stent all the lesions because there is no use, no fibrinolysis, no OMT. So stenting of the culprit infracranial artery is the answer based on the culprit shock trial. This is very important MCQ. Okay. So in hospital management, you know, you have to reduce after 24 hours. There is no chest pain. Patient can leave the bed and walk. Diet, bowel activity, sedation. All this you will be knowing. So then complications. Very important, sir. Complications will divide into mechanical, electrical, and pericardial. Main is mechanical. In mechanical, main is cardiogenic shock. So any patient in MI, anterior MI, extension anterior MI, you will be seeing the BP will be the patient in shock 80, 60, 70, 40. So this most common cause is acute LV failure. Most common cause of cardiogenic shock is acute LV failure. Most common cause of cardiogenic shock. This is very important. Because patient large amount of myocardium is necrosed. So there is a definition for cardiogenic. Not whenever I see a patient with RVMI, the patient will have low BP only of 90-60. Just you should not tell the patient with cardiogenic shock. See, this should be the frank hypotension below 80 or 90 millimeter of mercury, a reduction in MAP of more than 30 with cardiac index. Cardiac index less than 1.8 without support and less than 2.2 with support, or elevated end diastolic pressure. For example, you should do catch study. Right side pressure should be more than 10 to 15 and left side pressure more than 18. But what you can see is in clinical practice, frank hypotension with evidence of end organ perfusion. Patient is having increased urea, increased creatinine levels. Patient is having altered sensorium. This is cardiogenic shock. Not just one BP reading is low, it is not cardiogenic shock. So this is very important. This is the criteria for cardiogenic shock. Cardiac index you have to calculate 1.8 without support, 2.2 with support, and elevated end diastolic pressure. Next, whenever the patient cardiogenic shock, first you have to do PCA and open the infracranial artery. I have already discussed. Then you have to give inotropes, then vasoconstrictors. Otherwise, finally you can go for mechanical circulatory support with ECMO. All these things you can. Okay. Then coming to mechanical complication, all are true about papillary muscle rupture in acute MI except. The most common is not anterolateral, it is posteromedial. Posteromedial, it has all other things are correct. This is the answer. It has a bimodal peak. It occurs within first 24 hours or within the next 3 to 5 days. Then vasodilator therapy, it should be initiated as soon as possible. Then surgery is a mainstay of treatment. I told already, whenever there is mechanical complication, primary PCA takes a back seat. We'll discuss this detail next. 75-year-old female presents to the CCU with extensive anterior MI. Patient was laced with streptokinase. Patient developed pulseless electrical activity. This is very important key point. Following which she has collapsed. Which of the following is the diagnosis? Very good. There is a equal answer for most of the answer. Two of them answer correctly. It is the main is that pulseless electrical activity. The pulseless electrical activity. They will see 75-year-old age female. The patient would have a thin and akinetic myocardium. They would have lynched that patient. So the patient, the correct answer for this question is free wall rupture. We'll discuss this all these things in this. So mechanical complication, three things: free wall rupture, ventricular septal rupture, mitral regurgitation. So what happens in the for example, this is the myocardium. The free wall gets ruptured. Here the free wall gets ruptured and blood starts leaking into the pericardium and it causes cardiac tamponade and patient suddenly goes to death. Otherwise, what happens? The free wall gets ruptured and the patient and the pericardium itself can seal the patch and it can form a localized collection. So at the time, patient can survive. So these are risk factors. We already discussed that female reperfusion with the fibrinolytic agent. fibrinolytic agent increases the risk of free wall rupture. PCI decreases the risk. So SK increases the risk. That only we show. Next, old female. All these things are there. Hypertension, single vessel disease without collateral circulation. Very important. Whenever the patient is having collateral circulation, so there would be a reperfusion from other collaterals, and the patient would not gone to the MI, which is extensive MI. So at that time, patient would the free wall won't rupture. Another thing is main risk factor is anterior wall MI or first MI. What happens since repeated MI, the ventricle is this is a ventricle. This is a normal thickness, normal. Whenever the patient is having repeated MIs, the patient develops the scar. Scar is there. In that scar, it can't rupture. The scar can't rupture. So patient is having, when a patient comes with third attack, the risk of free wall rupture is less. So this is a very important chart. In this chart, you can everything is covered. So first we will discuss about free wall rupture, which we discussed already. See, fibrinolytic therapy does not decrease risk. It is a bimodal presentation, which we discussed. All three are bimodal presentation within 24 hours or within 3 to 5 days. It can present with anginal pain, then hypotension due to cardiac tamponade, all these things. So then main thing is, see here, electromechanical dissociation. This is we saw pulseless electrical activity. There is only electrical activity, no mechanical activity, and cardiogenic shock. Then here you can see the whenever you see echo, it will be high acoustic echoes, which in the blood clot will be in the pericardium. Then this one. Then papillary rupture. I told we discussed already. The most common mechanical complication is VSR. It is 3%. This is also MCQ. Most common mechanical complication is VSR. Then papillary muscle rupture, if we discuss, papillary muscle rupture, posteromedial is more frequent than anterolateral because anterolateral is dual blood supply. Posterolateral single blood supply. Same bimodal peak, abrupt onset of breathlessness, same murmur will be there. Acute MR murmur will be there. Then here you can see in echo, you can see the flare leaflets, your MR, all these things. Then VSR. VSR is also complicated. It also occurs when in case of this is the ventricular septum. So in the ventricular septum, whenever you have a inferior LMI, it can be basal VSR. Inferior LMI, it can be a basal ventricular septal rupture. Whenever you have anterior LMI, it is a apical VSR. Because the segments, this will be not anterior LMI, you have apical VSR. So same ventricular septal is the most common macromotion. It is also bimodal peak or shallow systolic murmur. Then you can see the color flow in these things. So all mechanical complications you should remember. Most common mechanical complication, clinical features is due to the rupture of interventricular septum, lack of development of collateral network, and advanced age, female sex, and chronic kidney disease. Whenever you see a patient after lysis or after some time, the patient is having cardiogenic shock and you hear a pansystolic murmur, you have to suspect ventricular septal rupture. This also we discussed. Posterolateral papillary muscle, because of its singular blood supply, more frequent. So then arrhythmias, everyone knows. Any arrhythmias can develop. VPC, ventricular tachycardia, supraventricular arrhythmias, sinus bradycardia, AV block. Our main concern is about AV block. So inferior LMI, there is a staged progression. First sinus bradycardia will develop, then first degree AV block. Then Mobius type 1 AV block. This is the most common. Then complete AV block. With this, what happens? It develops slowly, and if you revascularize it will again revert to normal sinus rhythm. Because in anterior LMI, whenever the complete CHP is there, it is infra-ECN block. The infra-ECN block, there is extensive damage to the myocardium. So you can't, even if revascularize, sometimes the complete AV block may persist. Whenever the complete AV block in anterior LMI, it is very dangerous than inferior LMI. Inferior LMI, after revascularization, it improves. So then pericarditis. So coming to the last question, 55-year-old female readmitted with fever, chest pain, and mild pericardial effusion. She had anterior LMI recently. Which of the following statement is not true? This is the last question for the day. Most of you have answered correctly. Very, very good. This corticosteroids are not the first line of treatment. So this is what is the syndrome called? It is Dressler syndrome. See, readmitted with fever, chest pain, pericardial effusion. She had anterior LMI recently. So here it is called as post-MI pericarditis, which is late post-MI pericarditis. It's called as Dressler syndrome. Here it can be associated with pleural effusion. ECG may be non-diagnostic because already patient is having Q waves and patient is having some STT changes. Classical pericarditis ECG won't be there. Usually presents a few weeks after MI because it's an immunological phenomenon. So the first line of treatment is mainly NSAIDs or colchicine. So other thing is, these are the pericardial complications. Mine is early infarct post MI pericarditis. This is very important. This is called peri-infarction pericarditis. Patient will have MI, after second day, patient will have again chest pain. You will suspect whether it is a reinfarction or whether it is a reinfarction or pericarditis. So whenever patient has pericardial rub and all, you can definitely see, and it is treatment is with aspirin only. You should not treat this with NSAIDs or nothing. This is with aspirin only. You should use high dose aspirin. Then post-MI pericardial, and which we discussed is post-MI syndrome, which is Dressler syndrome. And this treatment is NSAIDs and colchicine. Steroids you can use in refractory cases. Okay. This comes to our final discussion. Thank you so much.